Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8-Minute Rule. I am joined with Lucas and Mark. Drew is out, but we will hopefully have him back on the next episode. So one of the things we're going to do here today, I'm going to start with a fun icebreaker question. If you worked in one of my clinics before, you know that I love icebreakers in staff meetings, and everybody does. So, icebreaker for today is going for Lucas. Lucas, what is your favorite flavor of ice cream?
Dark chocolate.
Chocolate?
Dark chocolate.
Dark chocolate.
Yeah. Real dark.
Real dark. What's the difference between real dark and not real dark?
You can barely taste that sweetness. It's so dark here. It's
Okay. Cacao percentage is really high. Is that right? Am I saying that correct?
yeah, that's cool to describe. If you go to the grocery store, you get the Jenny's blackout ice cream. That will be about it.
Awesome. Good. All right. Thanks for that. Okay. Now, moving on. Today we're talking manual therapy. Everybody is excited to discuss. Depending on how much time we end up taking here, we're going to look at making this multiple episodes. Really, our goal here today is defining what manual therapy is and what it is not. Also, getting some takes from you guys on how you're using it in the clinic. We know there's a broad spectrum. Typically, even within you, I think probably Lucas, you're a little more heavy manual therapy than Mark would be in the clinic, and you guys both get awesome results. So really, what we want to do is talk over what it is and just get some perspectives around it for all the clinicians out there as well. So I'll start with the APTA's definition of manual therapy. It is the synergistic application of movement-oriented strategies, integrating exercise and manually applied mobilization and manipulation procedures. It's fairly broad. International Federation of Orthopedic Manipulative Physical Therapists defines manual therapy as a specialized area of physiotherapy or physical therapy for the management of neuromuscular musculoskeletal conditions based on clinical reasoning, using high specific treatment approaches, including manual techniques, therapeutic exercise. Orthomanual therapy also encompasses and is driven by scientific and clinical evidence by the psychosocial framework for each individual patient. All right, so a lot of words there. Really, again, what we're looking is backing out a little bit. For you personally, in the clinic, Mark, what is manual therapy?
So I think that both of those definitions are pretty solid and vague intentionally, because it can mean a lot of different things and should mean a lot of different things for every single patient. I like that both of those definitions actually include the incorporation of exercise or other non-manual techniques as part of manual therapy, because in my mind, manual therapy is more than just a manual technique. It is the environment that it is done in. It is the education that goes along with it. It is the combination of the clinical reasoning rationale, the patient's expectations even, and all of the things that encompass that manual technique. That's the reason that, my hand skills are, not tremendously better than anybody else's that's a physical therapist, but my manual therapy, I would argue, is superior to a lot of physical therapists because of how I implement that manual therapy. I think that's really what separates good manual therapists from a great one, or average from good, and so on. It is a very specific framework, clinical reasoning, and then identifying very specific manual techniques that you can then incorporate into the larger manual therapy framework.
All right, so biggest thing for you, Mark, the belief that your manual skills may not necessarily be significantly better. Application clinically is what's going to separate you, that you believe, which can make some sense when you look at uh, a lot of the studies as they try to validate manual therapy. Is it's very difficult to do because it is very provider dependent, um, in terms of how you go there. So a couple thoughts on that, but I want to kick it over to Lucas. Lucas, give me your feedback before on one what Mark talked about, as well as kind of your opinion. What do you see manual therapy for you?
Well, I'll start with the end of this question is what's manual therapy for me. My bias is use of hands-on to provide resistance and facilitate the movement on the patient's joint. Um, with that being said, I do a lot of muscle energy, a lot of contract relax with my patients, which is a form of assisted active manual therapy. On the grand scheme of things, what I usually start is a passive, followed by active assisted by resistant movement as a sequence that becomes an exercise. And with that, I can teach the patient how to exercise proic. So a third of my treatment starts with hands-on on that part. With in terms of what Mark was saying, is a constant mental exercise of testing, treatment with testing, whether you're testing the patient or not. We're testing the patient or not, you're constantly throughout the movement, throughout the technique, throughout the exercise, you are retesting consistently the patient and adjusting your force, your angle. The goal at the end of the day is maximize function, right? Which I will circle back to the iPhone, to which iPhone clearly states that the goal of manual therapy is to maximize function. If you go with the iPhone, you got to remember that iPhone is an international coalition of physical therapy associations for manual therapy. So we can go to Norway and there is not talking physical therapy program, while in America is part of the curricula, including cervical spine manipulation, right? So with this, you got to put it all together and use exactly what Mark was saying. The manual therapy is not a passive technique. It's not something you time. It's not something you do for a specific amount of time or specific amount of repetitions. It's a continuous, a dynamic part of the treatment that involves your hands-on with the patient going from passive to resistive.
All right, so I'm gathering from both you guys, and probably just where I'm getting stuck on is the difference between application of the technique in terms of the why and actually doing the technique. And so, I don't think you guys are exactly saying this. So I want to push back a little bit. Um, the ability to perform these techniques is important, though, correct? I mean, for you guys, I have seen you practice these skills. I've seen you teach these skills, and I know that your hands have hours and hours and hours upon technique that you worked on. And that has to matter some, correct? I mean, and Mark, especially as a fellow in training, you're going through it right now. There's a lot of focus on your hand skills, and so being able to practice them and perform them well, like that's got to have a lot of weight as well, too, correct?
Yeah, I think that's a good point. And it's going to go into like, what is manual therapy not here? Because yes, attention to detail matters. And, you know, hand placement, having soft hands, helping the patient feel comfortable with your touch and your application of force. Like all those things are definitely important. And those are kind of nuanced skills. But I can teach someone else to do a manual technique very quickly. It does not take someone with a DPT to be able to, mobilize somebody's knee joint or shoulder joint. Now, the constant assessment that Lucas was talking about, the constant test, treat, retest, but even assessment of what you're feeling, that's not something that can be taught in just a few minutes. And so manual techniques are done by many professions, really, many other competing professions. And they have outcomes, and some of them are good, some of them are bad. What makes a good manual therapist is the application of the manual techniques, the adjustments, the fine tuning, and then again, kind of the environment, the education, everything that goes along with just the manual technique.
I think Mark mentioned earlier something about the connection with the patient. And that is a big part of manual therapy. A lot of times patients come because they're gonna receive manual therapy. Um, and the misconception that I hear often from students is that patients become quote unquote um reliant on a therapist. It I don't think that is exactly true. The patients become connected with the therapist. And when the manual therapy stops, that transition needs to be very clear to the patient so that connection is not broken.
Yeah, so I like that. So kind of backing up a touch, and I appreciate, Mark, the differentiating between manual technique and manual therapy. Yeah, I think through sitting on the high school football bus and just bear hugging guys, pulling them up to cavitate their T spine. Is that manual therapy or is that a manual technique? But more your technique can get to doing that all over the place, right? And um, but the key being seeing the assessment behind it, and do we as physical therapists also see that and believe that? Because I think that's one of the things that does separate us in terms of the application, and it's a big difference between early clinicians and more advanced. I think back through one of our biggest struggles probably is practicing these techniques, because either we're not connecting those dots or realizing when it's a good place to apply it. And so we don't develop a lot of these hand skills that can be really valuable in the clinic as well too. So it sounds like we're driving a little bit more towards manual therapy being something that's it's gonna involve not just the hands-on portion to it, but it's got to have the clinical assessment as well piece too, and it being key for connecting with the patient, which I hear, especially Lucas, like you're talking about as well. So um, I like those two pieces. No, we're about out of time here, but anything that you guys want to add to sum up on this before we hold off to Phillips?
I'd like to be the consciousness of all clinicians to apply what they've learned, because whether or not they're in a fellowship or residency going through a formal training, you can learn techniques. You can learn to go from the technique to applying manual therapy on the patient. And with that being said, that becomes a lot more than just a passive technique.
Very cool. I like it. Awesome. Appreciate it, guys. As always, would love to get some feedback from the crew. So again, bring some discussion for this on the team's channel. What is manual therapy and what is it not? I think both those things are really helpful as we look to discuss and everybody to be able to grow a little bit. Again, we know there are a lot of providers out there that are getting results on both ends of the spectrum with manual therapy versus non-manual to some degree. So we want to have open minds to it and also be open to expanding our toolkit here. So appreciate the discussion and looking forward to part 2.